Now go on to our next speaker. Dr. Sirisha has joined, I see. So just like to briefly introduce her. She heads the glaucoma services at LV Prasad Institute based at Hyderabad, and she's another amazing glaucomatologist of our country. And she is going to be talking on a very challenging topic, management of glaucoma post-K-Pro. On to you, Dr. Sirisha.
Yeah. Thanks, Dr. Chitra, for the invitation. My video is there. I would like to play the video.
Yes, doctor.
Yeah.
Hello, friends. I'm going to be speaking to you about glaucoma and keratoprosthesis in the next since. Keratoprosthesis refers to artificial cornea, which is developed to treat end-stage corneal diseases. And this is not new. It's been there since 1850s. However, the problem was that these eyes suffered from poor retention rates. And it's only in the later half of the 20th century, with better designs and improved surgical technique and decreased infection rates, the improved retention rates is something that we see today. So type 1 keratoprosthesis referred to a type of keratoprosthesis which is similar to that of a corneal transplant, where the central part of it is an artificial cylinder which is sutured onto the eye, similar to that of a keratoplasty. So what are the anatomical retention rates that we see in our country? We know that in our country, being the tropical climate with the infection rates being very high, the retention rates are definitely less than what we see in the West. So it's as close to as 70% is what we see. And in the West, the retention rates are very good, 93 to 95%. Because these retention rates have improved, or rather the keratoprosthesis is retained for a longer time, glaucoma is a major blinding complication in these eyes. We evaluated the glaucoma in patients with type 1 Boston and orokeratoprosthesis in Indian cohort, and we found that close to about 61% of them had glaucoma, and majority of them actually required surgery for control of intraocular pressure, either prior to keratoprosthesis or after it. Not just the incidence of glaucoma is high in these eyes, as high as sometimes 90%, but also the progression rates are very high. So I'll take you through a case. This was a boy who was 14-year-old, presented to us following a cracker injury. You see the kind of severe ocular surface problem that he has. He underwent multiple procedures, and over the next 5 years and 14 surgeries later, and the last one being keratoprosthesis, his vision improved to 20/50. The interesting thing was his cup disc ratio was normal and his visual fields were also significantly fine. In the next 10 months, his glaucoma worsened despite medical treatment. His CD ratio increased to 0.9 and had an advanced glaucomatous damage. So this boy underwent an Ahmed glaucoma valve implantation, and following which his intraocular pressures were managed with additional medications, and visual fields were maintained at that level over the next 8 years. So why does this happen? We know that for glaucoma diagnosis, intraocular pressure assessment, optic nerve head and visual field assessment are very important, and intraocular pressure is what is monitored while treating them. In patients with keratoprosthesis, prior to surgery, because these eyes have scarred corneas, to record intraocular pressure or to evaluate the disc becomes a challenge. Post-surgery, evaluating intraocular pressure in these eyes with artificial cornea is again a big problem, because none of the currently available tonometers can actually record intraocular pressure over the artificial cornea. So what we rely on is a digital tonometry, which is highly subjective, and we know that it is not very useful. So with this question in mind, we wanted to test if a sclera can be used to record the intraocular pressure in these eyes. So we did an experiment which was published in 2019, where of the different tonometers that we used, we found that the Schiortz tonometer, when record the intraocular pressure on the temporal sclera, gave us intraocular pressures which were almost close to the GAT intraocular pressure readings. And the range of agreement between the GAT and the GAT intraocular pressure and the scleral Schiortz tonometry readings were very close. We use that information on the type 1 keratoprosthesis patients. And it was very interesting to build a training model from the data set that we got in the normal eyes and used to predict the GAT intraocular pressure readings from the scleral tonometry readings that we got with the Shear's tonometer. And the predicted GAT was evaluated. So this predicted GAT, like I said, the difference between the actual GAT and the predicted GAT in the normalized that we found was less than 1 millimeters of mercury, the difference. And this one also gave a very close reading. Since the conventional method of testing intraocular pressure in these eyes is finger tension assessment, we also saw between an expert checking the finger tension tonometry and the scleral Shear's tonometer, which was converted to a predicted GAT, we found that the accuracy was as high as 91%. So based on our research, we now use finger tension tonometry and scleral Shear's measurements to monitor intraocular pressure in these eyes. Angle assessment becomes very difficult. Sometimes ASOCT can be helpful to understand what's happening to the angle, and angle closure is a major problem in these eyes. Disc evaluation is definitely possible when the media clarity allows. Functional assessment, especially if the visual acuity is maintained well, is very, very useful because it can actually give you about 60-degree visual field assessment. Serial assessment is helpful to pick up the progression of the disease, and that will also help us to treat these patients appropriately. So how do we treat glaucoma in these eyes? Topical medications, we do start them in fact prophylactically, but what we do not understand is what is the efficacy, especially with its penetration through the artificial cornea. To a great extent, oral carbonic anhydrase inhibitors are very useful if the patient is able to tolerate. Glaucoma drainage devices, especially the valve devices, are very useful in these patients. If the conjunctiva is very poor and one cannot perform a GDD, then endocyclophotocoagulation is definitely a choice, or a transscleral cyclophotocoagulation. So in the presence of pre-existing glaucoma, and if we are planning to do a keratoprosthesis, we prefer to do a GDD prior to doing a keratoprosthesis. And that is definitely helpful if some amount of corneal clarity is present. However, if the cornea is very hazy, then we do a simultaneous K-Pro along with a GDD. In situations where a post-K-Pro glaucoma is diagnosed and then a GDD is performed later, and based on how the conjunctiva is, one has to choose a smaller or a larger device to be able to hold in these scarred conjunctivas. So our protocol in managing these patients with K-Pro is very strict, where we do a 2 to 3 monthly assessment of intraocular pressure with the digital as well as the Shear's tonometer. We do visual fields every 2 to 3 monthly whenever they come for a contact lens change, and prophylactically start them on anti-glaucoma medications. And whenever there is a slightest of doubt that either they have developed a glaucoma or the existing glaucoma is progressing, they do undergo a valve glaucoma drainage device surgery and are closely followed up post-operatively. So to summarize, keratoprosthesis is definitely a boon in helping this patient see, especially with severe corneal blindness. Glaucoma is a serious complication in the long term in these patients. Monitoring and diagnosing glaucoma in these patients becomes very challenging because of the way the IOP is assessed as well as the disc and visual field assessment is concerned. Early and aggressive treatment, both medically and surgically, is something that one needs to be thinking of. And GDDs are very useful in these patients. Unlike what we do with our regular glaucoma patients, very close and long-term follow-up is required for these patients. And visual fields, like I said, need to be assessed every 2 to 3 monthly. Thank you so much for your attention.
Thank you so much, Dr. Sirisha, for making it apparently simple the way you discussed it. But when you said you start them prophylactically on anti-glaucoma medication, so based on your IOP measurements, which are anyway quite gross, would you want to go to the maximum medical treatment before you look at surgical intervention? Because even your field assessment in those patients with limited vision is not going to be possible, even though you did mention 2 to 3 months, once in 3 months doing a fields and all that. So if the vision is limited, when would you take a call? You have to do GDD. Again, the conjunctiva might also be quite limited. Dr. Sirisha?
Yeah. So thanks, Yeah, thanks, Chitra, for that question. So we do start with medical treatment, and topical medications are given. But the question is, how well do these topical medications work for them? So we give them topical medications, and I specifically try and also add oral anti-glaucoma medications for them. And when I say close follow-up, we do many. In fact, when I showed the data, this is a question that the reviewers also asked. Why is it that you don't do a GDD in every patient? GDDs are not without complications in these eyes. You only do it when they are necessary. So medically, we manage them. Majority of them, we can take care of them medically. Borderline pressures and visual fields is if the vision is all right, we can definitely do a visual fields in them. It's never a problem. So medical management, and if digitally IOP is not getting controlled, or with the shiots, we know. So with the shiots, anything that is recorded beyond 14 millimeters with the shiots, to me, it is high intraocular pressure. Plus, since we do it serially, we know how the pressures were prior. So that also is something that we take consideration of. That means the progressive increase in pressure, or IOP that is greater than 14, or if the visual field is showing a progression, then we take it up for an implant surgery. Again, we need to remember valved implants is something that we do in the not something that you would, the complications is not something that you will accept. So we need to remember that. So doing a surgery is very simple, but then the problems that are associated with them and post-operative follow-up,
yes,
still is a challenge.
Dr. Shushmita, you want to add anything? Murli, you want
medical management, if not, then only surgery.
Yes, Dr. Sirisha. Dr. Shushmita, would you want to add any point on this? And Murli, any question before we move on?
Sirisha has covered most of it. There's nothing much to add. It's very interesting that ultimately it is our fingers and our clinical acumen that help us with all the gadgetry that we have. But I think very well put. She probably has the maximum experience from all of us. So thanks, Sirisha, for that lovely presentation.
Yeah. Murli?
Madam, where exactly would you position the tube? Like the anterior segment is totally deformed. So would you position it in the anterior chamber, or do you do a pars plana? That is question number 1 for the type 1 keratoprosthesis.
Thank you.
For the type 2 keratoprosthesis, there's hardly any conjunctival cover. So, and even cyclophotocoagulation or cyclocryotherapy may not be possible because the sclera is covered by such a thick mucous membrane in the type 2 keratoprosthesis. So, what would?
Yeah, so I think they're very important questions. So I would divide them into 2 parts. One is type 1 keratoprosthesis. We need to remember have very high incidence of glaucoma. So type 2 keratoprosthesis, fortunately, since you remove majority of the things, including the anterior, the cornea, the iris, and vitrectomy is also performed in them, the chances of glaucoma in them is far less. So in a type 1 keratoprosthesis, all the problems related to a keratoplasty are there, because we haven't really removed everything and removing posterior capsule. So although these eyes are left aphakic, posterior capsule is something we leave them intact, because to prevent the posterior segment complications, again, we have shown that removal of the capsule is not a good idea unless it is an aphakic patient to begin with. So majority of them, I think the location would be a sulcus placement as far as I'm concerned. If it is a completely vitrectomized eye, then obviously pars plana or sulcus, it really doesn't matter, because the location is somewhere 2 to 3 millimeters behind the limbus. So that's what we will do. If it is a type 2 keratoprosthesis and your tissue orientation is very difficult, what we do is measure 9 millimeters from the center of the cornea. And that is likely to be the area, because if you say I divide 12 into half, 12 if you say is the white to white in an adult, half of it is 6, add 3 to it is about 9 millimeters, and that would be the approximate area where your pars plana is located. So that's the area where you enter. But even if you want to locate, that is the location for your pars plana if you have to do an intraocular procedure, or a pars plicata if you have to go maybe 1 millimeter anterior to that, we can do a TSCPC. But I would prefer to do an endo CPC in these eyes.
Okay. Okay, shall we go on to our next speaker? I think that was an amazing amount of information.